All right, Matt. So, uh, first of all, like, can you introduce yourself for the audience?
Yep, my name is Matt Buckley. I'm a performance physical therapist. I currently work at Exos in Phoenix. I've been at Exos for about a year. Prior to my time at Exos, I worked as one of the team physical therapists and assistant strength coach for the Detroit Red Wings, the NHL. So, spent 3 seasons with them prior to coming to Exos.
So, do you mainly work as a physical therapist at Exos, or you also have like a dual role, like a performance coach?
So right now, I'm primarily working as a physical therapist. I have my CSCS and have experience as a performance coach, both with the Red Wings and at a facility that I worked at prior to the Red Wings as well. So um, the goal is to kind of build into kind of that hybrid role with doing a little bit of performance coaching as well as physical therapy. So moving into 2024 this year now. That'll be my goal and goal going forward with Exos. So
Well, so I know we talk a little bit about like what kind of athletes you work with and like uh all those group, but still like can you like talk a little bit about like basketball, football? I know Exos have a lot of like different types of athletes. So what kind of athlete you work with?
yeah, we kind of see a huge variety of athletes. So basically, every off season we'll get athletes in. So right now we're kind of finishing up our MLB off season. So we've got about 20, 25 guys, I think, in house for an MLB off season. And as that's kind of coming to an end through the end of this month and beginning of February, starting in January, we have our big NFL Combine training, which obviously Exos has a big following for that. So we get a lot of guys in house for that. So that's rolling right now as well. And then we also will have the NFL offseason that'll starting in February, moving into March, all the way through April, May, June. Some guys will stick around all through the summer as they kind of go back and forth between OTAs, uh, team team events, and things like that. So that'll keep us busy through the early summer. And then last summer we had a pretty big NBA group as well. So we'll get a fair number of NBA guys that'll come in, do their off-season training there, and then we'll roll right back into the fall when baseball starts. So get a good variety of professional athletes. We do get a lot of we have a lot of other sports as well. We had some track groups that came in both nationally and internationally that have come through this past year. We had an Australian rules football team that came through last year too. So that was really cool to kind of work with a group of athletes in a sport that, I had never really seen or heard of before. So we get a wide variety of people. And then also, Exos has a good tactical side as well. So a lot of tactical athletes, first responders, groups like that will come through as well. So we really get a really wide variety.
Nice, nice. So what sport do you like the most? Like,
So I've really enjoyed. I played football growing up. Played football in college, so I always enjoy working with football. I've actually really enjoyed. This has kind of been my first opportunity to work with baseball, and I've really enjoyed working with the baseball athletes. A lot of similarities to what I saw in hockey as well, both personality of the athletes and demands of the sport to a certain extent. So have really been enjoying working with baseball. But really, man, like I played every sport I could growing up. I just love sports in general. So I couldn't really say I have one favorite over another. It's just I like the variety and working with different sports throughout the year.
cool. So you mentioned at the beginning you were the physical therapist at NHL, right?
Correct. Yep.
And then go for 3 years and then go to Exos. So for all those experience, you probably build up your own movement assessment. So can you like walk us through like what kind of movement you're gonna do and like what will you be looking at?
Yeah. So right now at Exos, so we utilize a basic movement screen for each of our entering athletes. It's basically, concepts from the SFMA, FMS, some other basic movement screens. And I think those are all, decent starting points for looking at a movement screen. I think the overall goal, you're kind of looking at some global movement patterns, whatever those may be. And then from there, you're trying to break down those patterns into the individual pattern components and trying to further identify, what may be causing an abnormal movement pattern. So let's say, for example, you're looking at a overhead squat pattern. And they have, inability to, get to 90 degrees, or they have a excessive trunk forward lean, or, posterior hip shift, or whatever the case may be. Okay, you notice there's an abnormal, global movement pattern. Well, that could be caused by a lot of things. It could be lack of T-spine extension, lack of shoulder flexion or lat length, poor hip mobility, hip internal rotation, closed chain dorsiflexion. Maybe it's just neuromotor, neuromuscular control. So, you know, identifying a abnormal movement pattern is great. And then from there, I think it's important to identify the subcomponents of that pattern and then break that down and identify, okay, what might actually be causing, the root cause of this issue. And that, does a good job at getting you down the right path. I also think it's important to look at different strength measures. So, we have all kinds of things that we'll utilize, whether it be a, functional strength test or, handheld dynamometry. We have a tension device where you can get isometric strength testing from that. Obviously, we use VALD, so all of your force plates, force frames, Nord board, really any isometric, uh, you know, strength testing you want, you can get through there. And also, some of the things that I personally have started to look at more as I've gotten throughout my career. We had a DNS symposium at Exos in November of last year, and I had been exposed to DNS with some past colleagues, but that was my first opportunity to like take a course and really get immersed in it. And I just thought they did a great job at teaching how to, first of all, assess, how a patient braces and looking at intra-abdominal pressure, and then how to correct for that. And how, inability for a patient or a client to brace appropriately, not just going to cause potential for, low back pain, right? But really problems throughout all upper and lower extremities, and an inability to properly brace can affect movement, throughout the whole body. So that's something I've started looking at a lot more. And the last thing that I personally look at a lot more now, again, based on, seeing some other really great clinicians who I've worked with in the past, and then taking a clinical neurodynamics course about a year ago, have really started to look a lot more at neural mobility and nerve sensitivity as well, and looking at your slump test, straight leg raise, and then all your upper limb tension tests, and helping to identify how a potentially seemingly musculoskeletal condition or pain or pathology may actually have, especially if it's a recurrent injury or a chronic pain or chronic injury, oftentimes there is some amount of nerve and neural mobility or hypersensitivity involvement in that as well. So those are some things that I personally have been looking at a lot more lately. Obviously, not looking at all of that, within one patient at one time, but those are different things that I'll pull from when I'm trying to get just like an overall picture of the patient in front of me.
Cool. So how long is the process if an athlete go to you and go through all the movement? Is it strictly like SFMA and just
Uh,
after SFM break it down to the table?
Yeah, so I'd say our movement assessment is roughly 20 to 25 minutes. And then from there, then I'll start to go into any of the other things I mentioned. Like I said, I'm not looking at all of that with every single client. Just, we'll pull pieces from that based on what I'm seeing in front of me. So yeah, it's roughly, if we're looking at a full, evaluation, anywhere 30 to, 45 minutes probably.
Well, that's long.
Yeah, yeah.
So did any like I know you guys just finished like weeks ago, like just finished uh the testing for NFL guys, right?
For the NFL Combine, yeah, they
Yeah.
all entered first week of January. January 2nd was day one of Combine training. So Yep, we get a lot of those guys in, so that we're running them through that basic movement screen. At that time, like I said, when we have so many bodies coming in, more like a team setting, right, where you've got 15, 20 athletes entering in a day, and you're just trying to screen all of them, seeing them all for the first time. That's where you're looking at about that 20, 25 minutes, looking at the movement assessment, getting a global picture of that athlete. And then from there, we've got them in house for the next 8 weeks. So we're going to do physical therapy with every guy, healthy or not. And from there, then in future sessions, I can dig deeper into some things that maybe, I may want to look at, or maybe causing dysfunction or whatever. So doesn't always necessarily have to be done on that first visit. But trying to get as much of it as you can to kind of set you down the right path, I think is important.
I know, I think it's like 4 years ago when I was at Exos, Arizona. I know you guys have like 3D motion capture, am I right?
We do have that capability. Used it much personally. I think we're still kind of working out some of the technological kinks with some of that stuff. And for again, a time like the NFL Combine where you have so many guys coming in, that's it's like kind of like what you mentioned. How long is that going to take? For each guy, you could be looking at upwards of an hour. So not something that we do typically. We will. There, Exos has involvement in some research projects and things like that, and they'll use the motion capture stuff a little bit more.
Cool. So, besides like movement assessment, I know like there's more and more coaches gonna discuss about like fascia sling and how fascia gonna affect like mm, overall how athlete move. So can you like talk a little bit about like what is fascia?
Yeah. So, as just kind of a broad term, fascia is basically a sheath of connective tissue that runs throughout your entire body, and it connects basically our entire body. It encases all of our organs, muscles, bones, all nerves, arteries, veins, really encases everything and connects everything to each other. So, and some interesting things about fascia, aside from just being connective tissue, it also has a lot of mechanoreceptors, so it's very involved in proprioception, and also has a lot of nerve endings. So sensing, direction and movement and pain and things like that. And then different types of fascia have different amounts of collagen, making it more rigid or more, pliable, which either helps with stability or movement or that. So it's a very complex organism in the body that I really, have a kind of a basic understanding of. We have Structure and Function has a fascial manipulation course that's by with Steco, and that's actually coming to Exos March 8th, 9th, and 10th. So just in a little over a month here. So I'm excited to get in with that and be involved in there and learn a little bit more about the nuance, and really then getting into more of the treatment of fascial manipulation and integrating that into another tool in the tool belt for patients as well. So
Nice, nice. So I know that um if people look up to fascia like in Google, there's gonna be like how many is that? Probably five like different fascia sling like uh deep longitudinal sling, like lateral sling, those kinds like can you like walk us through or like give an introduction on like these kind of sling like
yeah, I think the most common fascial slings are the anterior oblique sling and the posterior oblique sling. So if you think about kind of making an X across the body through the front and the back, you also have the deep longitudinal, like you said, that's kind of like the paraspinals, multifidi, and bicep femoris on the posterior side, and then the lateral sling as well. But I think the most common are the anterior and posterior oblique slings. And the anterior oblique sling essentially is if you're looking at it, it would be left side internal external oblique, and then the right side adductor group, and that's connected through the abdominal fascia. So kind of making that X across the body. And then posteriorly, you're going to have, your glute max on one side and your lat on the other side connected through that thoracolumbar fascia. And so those are kind of the biggest and I think most well-known fascial slings. Um, and then kind of going into like, well, how does that affect movement? So if you take just like gait cycle example, for example, walking, right? So you take a step forward with your right foot, you've got right hip flexion, relative internal rotation, and adduction, right? Then on the left side of your body, for that left arm to swing forward, you are getting right sided trunk rotation, which is essentially mirroring that anterior oblique sling, right? So that right hip, you've got activation of the adductor group. And on that left side of the trunk, you've got the internal and external oblique to have that arm swing forward and to slightly rotate the trunk to the right. While that's happening at the same time on the other side, you've got left hip extension and relative abduction and external rotation. And as that right arm swings backwards, then you've got that lat creating that shoulder extension. So there you have the posterior oblique sling that's activating kind of at the same time. And really those slings, in a perfect world are mirroring each other and moving and stabilizing appropriately to create fluid movement as you go really throughout, all movement. But even at the basic level of just walking.
So, go back. I want to go back to the movement assessment. While you do your movement assessment, would you also check the function of the sling, or you kind of like use different approach?
So I think the way, at least that I personally will do it. So if I identify an abnormal movement pattern, I'm going to look at the subcomponents of that movement pattern. And if you see, okay, let's say, they lack, hip extension. But then you also notice maybe they have some thoracic spine rotation abnormalities or shoulder extension abnormalities or different things like that. That's where you can start to put the pieces of the puzzle together and thinking, okay, maybe this isn't just an isolated joint mobility or soft tissue mobility dysfunction at the localized point, but it may be a dysfunction throughout that entire fascial sling that maybe manifests itself as lack of hip extension, but maybe either lack of mobility through the opposite side anterior oblique sling or lack of stability through or proprioceptive input through the posterior oblique sling. So identifying an abnormal movement pattern is great. And then that's where I think the key is identifying the subcomponents of that and helping you paint that broader picture and really still looking at an athlete from head to toe and not just, I think as clinicians, and I definitely, am guilty of trying to get hyper focused on, okay, here's the level of pain. I want to look at everything there, but let's step back sometimes and take a look at a bigger picture and see if maybe there are some things along that fascial sling that may be contributing to the abnormal movement pattern.
So let's say if one person or an athlete's like posterior oblique sling is like maybe dysfunction, will you like train the whole like from let's say from left to right sling, or you're gonna like separate to like train their lat, train their like glute.
So yeah, so depending on again, what you find abnormal or dysfunctional in the individual components, oftentimes what I'll do is train the individual subcomponent in isolation. And then once you've improved whatever qualities you're looking to improve at that specific group or area, then you want to tie it back into the larger sling. Like, for example, let's say you identify maybe an athlete coming off of an adductor strain or just adductor dysfunction, tightness, weakness, whatever the case may be. First, let's address the adductor itself. Let's improve its mobility. Let's improve its strength, its tolerance to load, whatever the case may be. But we know that just isolating the adductor is not necessarily going to get whatever their ultimate goal is, whether it's returning to sport or play or whatever the case may be. So now let's take the improvements we've made locally and let's build that into the whole system. So that's where you then maybe look at like a Copenhagen plank is a great example of, okay, first we've done our isos, we've done our range of motion, whatever, we've improved the qualities of the adductor itself. Now let's retrain it to work through that anterior oblique sling by putting you in a side plank, activating, the opposite side internal external oblique, while that top leg's, on the Copenhagen with the adductor. So now you've got that whole anterior oblique sling working. And that's great. Now you've got it in an isometric way. You can also, you can load that through movement as well, however you want. And then take it a step further, then that's where you'd go into maybe, a split stance chop or a split stance med ball slam, or, something like that, where you're now moving through that that sling with some velocity or with intent, or whatever, use your creativity and whatever that athlete or that person in front of you needs, or whatever their goals are. Tailor your ultimate intervention towards trying to achieve that goal. But I do think it's important to identify and treat the individual aspects, and then build it into those larger movement patterns.
I like it. So, um, I know there's coaches gonna debate about like fascia sling training, or like some people call like muscle activation, all those stuff. Like, if we, let's say, use your example, like they have a adductor strain, and if we just focus on it instead of like doing like the process like you mentioned, uh, is like, is there gonna be any difference?
Difference in how
Like,
you would.
let's say how they move after the injury.
I think so. I mean, I think if you only train, an area locally, and don't build it into those larger movement patterns, I think that's where a lot of the like neuromuscular control piece may still be lacking. They may have good adductor strength and good range of motion, but if you didn't pattern it through running or kicking or whatever that athlete needs, I think there may still be some potential for dysfunction there. And yeah, you can call it a lot of different things. You can call it fascial training, you can call it functional training, you can call it total body, like whatever. I tried to get caught up in the nuance of terminology, and instead look at, are we training the athlete through, the total body and through the entire, gamut of what they need in order to, achieve their goals or return to play or whatever the case may be.
Cool. So, Uh, I know a lot of like physical therapists, a lot of like coaches gonna start with isometric, then increase movement, then increase speed. Why do we want to start with ISO and then like go to like more speed on the movement?
Yeah, so I'm a big isometrics fan. I do a lot of long duration ISOs, especially early on, from a muscle strain and even just for muscle weakness. So if you go all the way back to your force velocity curve, isometric, especially in mid range position, no velocity, so you're able to produce the maximal amount of force. And I think early on, that's what you're trying to do is kind of retrain the muscle and the nervous system, neurological system, in that area, that hey, it's okay, it's safe, and it's tolerable to produce a large amount of force through this specific movement. And I think especially coming from someone who has had pain or previous injury, when you add in velocity and movement to that, that's where you're going to get compensation, you're going to get guarding, you're going to get weaknesses. So kind of breaking it back down, and we know isometrics have an analgesic effect as well, and pain reducing effect. So I'll use them a lot for that as well. And really long duration, 20, 30, 45 seconds, really as long as you can get by without the patient being like, dude, I'm not coming back because all you did is have me do wall sits all day. So, I'll use a lot of that early on, and I'll also integrate it not just within the mid range for that muscle or that movement. But I'll also do longer duration isometrics in a shortened and lengthened position as well. That's something that, a previous director of performance that I've worked with utilized a lot, was not just ISOs within a shortened range or within a mid range, but also a shortened and lengthened position. And then again, you're just kind of reteaching the body and reteaching that nervous system and the nerves that innervate that area, that, hey, it's okay to produce force even in a lengthened position, because we're able to do so early on isometrically without any velocity, and improve the body's ability to produce force in that position. And then once you've achieved that, that's where you then go into, concentrics, eccentrics, things like that.
Nice, nice. So, uh, I know Exos has their own like framework or their own system. So is it basically like activate the muscle, then movement skill, then speed, that kind of stuff, right? So as like you guys are physical therapists, how um let's say NFL combine group is like 8 weeks, right? How often do they need to change their like corrective exercise or like fascia training, at muscle activation, all those stuff?
Yeah, well, progress them kind of as tolerated. It depends on the patient that's in front of you. A lot of those guys, especially if they don't if they have a previous injury or pre-existing thing, something that's been chronic for a long time, that's where it's going to take a little bit longer to make changes. Um, Honestly, we're kind of fortunate in that we work with some of the highest level athletes, in the country. So a lot of times you just need to provide a little bit of stimulus, a little bit of input, really keep it basic, and their bodies are going to do the rest. So I try to not overcomplicate it, especially with some of those high level athletes, because their bodies make adaptations so easily and so quickly. Sometimes, not all the time, obviously, but sometimes. So that's something where, okay, like we may be moving on from isometrics very quickly, right? Like you may have achieved, let's say we saw in the force train they had a 20% deficit in hip AB or adduction, and within a week now they've improved that and they've got full, isometric strength in a mid-range short and lengthened position. Might be a week later. Not everyone's going to be able to achieve that, but some of these guys can. So now that's where, okay, we're going to move you on. I think that's where it's important to have some baseline objective testing and having some actual metrics that you can look back on, because that's really what I use to help dictate my progressions. I don't want to put somebody in a Copenhagen plank or doing a, med ball slam if they still have a 20-30% deficit in their adductor, right? But if we have identified that and then we retest it a week or 2 weeks later and that's improved, well, now how much are we really gaining by continuing to do, mid-range isometrics? Now we want to move into those higher level movements. So I think it's important to have some objective testing early on and then be able to continue to reassess that and look back at that to help guide your progress.
Cool, cool. So I'm gonna jump in the next topic. I know like speed power athlete like football, wide receiver, running back, or like some track athlete, they oftentimes gonna suffer from like hamstring strain. And uh when we're gonna assess hamstring like mobility, we're probably gonna use straight leg raise, right?
Mm-hmm. Yep.
So
Yep.
can you like walk us through like uh if you're gonna do a straight leg raise, active straight leg raise, what what are we looking at?
Yeah. So, in general, just as a basic idea, you're looking at that athlete's ability to move through active hip flexion and then therefore lengthen the hamstring on that side. And so, some of the things that you want to look for there, first of all, what I'll do is I'll cue them. So if you're looking at a straight leg raise, you want to make sure it stays a straight leg raise. So I will cue them to quad set and squeeze their quad really hard on that side and maintain that as they go, so that as you start to get into hip flexion, as you start to run out of mobility through the hamstring, sometimes you can start to get, your most common computations are either going to be a knee flexion on that side to shorten the hamstring distally, or you're going to get posterior pelvic tilt as you run on length to try to improve the length of that hamstring proximally. And so I'll cue them on the side we're doing the raise on, squeeze that quad and maintain that quad set as you go through. And then you can either yourself or somebody else stabilize the opposite leg, holding it down to prevent that posterior pelvic tilt. Or you can have them actively do a glute set on that side, that opposite side, or just like active, hip extension isometric into the table to try to minimize that pelvic tilt. And then I think the key is just having them move slowly through it, and then either using your assessment tool or your eye or whatever to see when they start to compensate, because they will, no matter what you tell them to do. They'll lose the quad set, they'll lose the glute set, they'll start to move the pelvis, whatever. So just having a good eye for that and then stopping them at that point and then taking that as your measurement. And then really the key is however you do it, I think it's just important to do it the same each time, so that you get consistent data. And so that, again, going back to that reassessment piece, you want to make sure that you're reassessing accurately each time so that you're getting, any changes you are getting are actual changes to that tissue and not just changes in the way you did the test. So I don't know that one way is better or worse than the other, but just make sure you do it consistently, account for compensation in some way, and then keep it consistent.
Cool. So you mentioned you're gonna like ask them to like squeeze their quad while they raise it, and the other side probably uh are you gonna ask them to like push down or no?
Usually what I'll do is I'll just have somebody hold that leg down, because yeah, if you're trying to get him to squeeze the quad on one leg, squeeze the glute on the other, it's just, a lot of times that coordination isn't necessarily there. So I'll either have somebody hold that leg down, or I'll just watch. I'll, have my, whatever I'm measuring them with, have that on them, and then as soon as I see that compensation, that's where I'll, okay, stop, take my measurement there, and then go from there.
Cool. So if you let them activate, squeeze your quad, squeeze your glute, so that basically take out the uh stability part of the uh active straight leg raise, right? Which I think is really smart.
Yeah. Yep.
So
Yeah.
if you're gonna if let's say if they have that kind of like can't stable their uh hip or pelvis, um what would you do to assess that, and like how like can you give us some example exercise to like correct it, help it?
Yeah. So I think, one thing that maybe you're kind of alluding to is maybe a discrepancy in their passive versus active straight leg raise. And that's something that we look at. Typically there's going to be about a 10-degree difference in your passive versus active. But if you have a larger discrepancy there, or you see them, like you said, like at, maybe passively they have, 80, 90 degrees of a straight leg raise, but then actively at 50 degrees, they lose the knee extension, or they start to get pelvic movement. That's just saying, okay, it's not necessarily a range of motion issue, because they have the passive range of motion. They have the ability to get there passively. They just can't control it actively. So the things where I would first go with that would be back to those DNS concepts and back to the intra-abdominal bracing, because that's where I think a lot of times, if you don't have the ability to brace and stabilize the pelvis and rib cage appropriately, that's where you're going to start to get some aberrant and alterations in movement. So that would be the first place that I would go.
So can you give us a like example of exercise, corrector exercise, or like you will do?
Yeah, I would get them into, maybe start basic, like your dead bug, or like your 6 month supine position, and just start to first get them, in a position where you can teach them how to brace appropriately, how to expand, depress the rib cage, expand the abdominals, and really create that whole cylinder. Um, and then from there, once they can achieve that without any movement, then you start to add movement. So if you think of it in a dead bug position, now, okay, now let's flex shoulder. Let's extend the leg. Let's go in and out of hip flexion and extension. Let's add a stability ball and start to do your reciprocating movements. Let's maybe add some rotational components to it. Whatever you decide and whatever that athlete needs. But starting with just like a dead bug, isometric assessment of their ability to brace, and then introducing movement there once they can brace appropriately. And you'd be surprised, even some of the best athletes, I've seen don't do a great job at bracing. Now they're amazing at compensating and they're very strong and powerful. And so they create a lot of force and stuff. But, that's also where you can get potential for pathology, for pain, dysfunction, things like that. So just because it's a super high athlete, don't necessarily think like, oh, you know, they can squat 500 pounds, they must be able to brace appropriately, because that's not necessarily the case.
That's if probably a lot of athletes have that kind of like issue, right?
A lot. Yeah. Yeah. The super tight paraspinals, that anterior pelvic tilt, super powerful, strong hip flexors, super strong glutes. Yeah, it's a common thing. And again, you know, and then you can kind of get down into the weeds of like how much do you want to correct, right? Because how much do you want to change an athlete who is already coming to you at an incredibly high level. But I think just where kind of trying to make those small basic changes and small basic improvements will ultimately give them what they need.
Nice, nice. So basically, that's all the question I have for you today. So for those who are interested in what we are talking about today, where can they reach out to you?
Yeah, Instagram's probably the best. It's just M Buckley, my last name, Buckley, 06. You can find me on Instagram there. Any questions, feel free to reach out. And yeah, thanks for having me on, man. I really appreciate it. It's been fun.
Thank you.